Hello, this is Dr. Kathleen Walsh. I'm with the Department of Family Medicine at the University of Wisconsin. Today's FAM Medcast is on elder abuse. I welcome Dr. Stiles, a geriatrician in the department. Dr. Stiles, thank you for coming.
Oh, it's a pleasure to be here, Dr. Walsh.
You know, we all hate to think about anyone being abused, and particularly the elderly. What is the prevalence of elder abuse in society today?
It's estimated that in America, approximately 1 million Americans over the age of 60 per year are abused. We know it's probably vastly underreported, so it's important to try to assess for red flags, for risk factors, and detect it earlier.
What are the types of elder abuse?
There are 5 types. We have physical abuse, psychological abuse, material abuse, which is the misuse of one's elder's property or financial resources, neglect, where there's significant danger presented to an elder's physical or mental health when the person responsible for his or her health is unable to provide for them, and then also self-neglect, if the elder is unable to provide for themselves.
You know, with the aging population, we, as primary care physicians, we're all going to see many more elderly patients. How do we determine who's at risk for elder abuse?
I look at this 2 ways. So you have both person that's at risk, the elder that's at risk, and then also there's risk factors for the caregiver in terms of caregiver stress. So let's talk first about the elder. Elders that are more at risk are women, advanced age, increased dependency or isolation, history of alcohol abuse, or if the elder has a history of past intergenerational conflict. In terms of the caregiver risks include, does a caregiver have a history of alcohol and drug abuse, mental illness? Are they socially isolated or have a poor self-image? Are they financially dependent on the elder they're caring for? And not uncommonly, we see people forced by circumstances to care for the patient, and so this is certainly a risk factor.
Are there red flags that we can look for during a general examination or on the phone, or the interaction between family members in the room during an exam that we can pinpoint and start going down that road of looking for abuse?
Definitely. So you really want to concentrate on the interaction. Is the caregiver speaking for the patient? Are they interrupting the patient? What's the general demeanor between them and the patient? Or are they not coming for appointments? Do they not care? Are there no-shows? Or alternatively, are these people coming in frequently, especially ER visits? Are there commonly medication errors? Are there any physical signs of abuse? These are all red flags.
In the primary care setting, what's the best way to screen for abuse?
Well, first, you want to interview the patient alone. The caregiver is abusing, the patient will not relay this in front of the person, so you want to interview the patient alone. The questions should touch on all forms of abuse. Examples are you afraid of anyone at home? Are you alone or isolated a lot? Has anyone taken anything that was yours without asking? Have you ever signed a document you did not understand? So you really want to touch on all forms of abuse, from financial, physical, and psychological.
So if we do find that there's some sort of abuse going on, how do we manage and work with that?
The best things we can do as physicians primarily is document. So documentation is key. You want to document the medical history, social history, if there are injuries, a detailed description of the injuries. You want to be precise and thorough if this would ever be used in a court of law. You want to do a safety assessment. Are they in any immediate danger that they need to be removed from where they are? Then you want to prevent social isolation. Also look at the caregiver stress issues. Are there ways we can decrease caregiver stress? And then manage medical issues.
As a physician, what is my responsibility for reporting abuse? Where do I go from there?
This varies by states. Currently, 42 states have mandatory reporting laws. Wisconsin has voluntary reporting. Each county has a 24-hour call line. Investigation must begin within 24 hours of the report. But I want to emphasize that the goals of reporting are 4. Verify the abuse. 2, develop a case plan. 3, utilize the least disruptive action to maintain the patient in the least restrictive environment. And 4, offer the patient services.
So what are your take-home points for us in primary care regarding elder abuse?
My take-home points are 3. Number 1, elder abuse is more common than we think. 2, physicians should be familiar with the red flags and screen for elder abuse. And 3, the goal of reporting is to keep the patient at home and enlist resources.
Thank you, Dr. Stiles. It's very informative.
You're welcome.